Thank you for inviting me here today to speak on the context of stigma surrounding STIs in the U.S. I want to acknowledge funding from the following sources at NIH and Yale behind this work that I'll present. So not all stigmas are equal. We once asked 1,200 members of the general U.S. population, as well as about 70 of the top experts in the field of stigma studies, to rate every stigma we could think of in terms of the features that have long been used to characterize stigma. So things like whether the person can be seen as responsible for the stigma, how disgusting the stigma is, how perilous it is, and how much blame, how blameworthy the stigma is. We then use these ratings to create a taxonomy of stigmas. And we found that chlamydia, gonorrhea, herpes, and HIV were among the most perilous, blameworthy, and disgusting of the stigmas. That is, people see these stigmas as having the same qualities as dealing drugs, being homeless, and being a criminal. We labeled these the quote-unquote threatening stigmas. And in fact, the distance that the average member of the US population wants to keep from people with STIs is about the highest of any of the other stigmatizing conditions, only exceeded by stigmas like being a gang member and being a sex offender. So I'll organize my 15 minutes in terms of the psychological mechanisms through which stigma might drive STI risk. So emotion dysregulation represents the first mechanism. So specifically, using that earlier data set, we found that the higher the public stigma towards your condition, the more dysregulated your emotional experience, and the poorer your behavioral and mental health. Thus, stigma can drive behavioral health risk through driving a lack of control over one's emotional experience. Stigma and emotion dysregulation also make the thin skinner, and that they lower the threshold at which one's mental and behavioral health succumb to general life stress. So I'll review several such mechanisms through which stigma might drive behavioral health risk. And while these processes might work similarly across stigmatized groups, I'll illustrate them through the lens of gay, bisexual, and other sexual minority men, given that this population exemplifies the intersectional burden of STI stigma that co-occurs with the stigma placed upon the populations most affected by STIs. So to illustrate another set of mechanisms through which stigma might compromise behavioral health, in a sample of 400 highly sexually active gay and bisexual men in New York City, these men had on average 9 sex partners in the past 90 days, we found that stigma in the form of childhood peer rejection and adult discrimination was associated with the extent to which these men chronically, anxiously expected rejection in their day-to-day lives, and the extent to which they had negative views of themselves as gay and bisexual men. which we found to be associated with, again, depleted emotion regulation, which in turn was associated with mental health risk. In fact, mental health risk is a core component of behavioral risk for STIs, with depression impeding the initiation of health behaviors, with anxiety driving avoidance behaviors, and with substance use driving impulsivity, especially in the context of sexual decision-making. And we find these processes predict not only mental health, but also in the case of these men feeling and behaving as if they were out of control of their sexual behavior, perhaps using sex as a way to numb the painful feelings ultimately stemming from stigma. So while childhood bullying and adult discrimination represent the sources of stigma in the cascading model that I just showed, increasingly, as Kim and others have mentioned, stigma is also thought of as more than just one person doing something bad or mean to another person, but instead is seen as is built into our structural surroundings. Indeed, stigma can be codified in terms of the laws and policies and community attitudes surrounding disadvantaged populations. So we linked one of the largest known data sets of MSM, the European MSM Internet Survey, which contains about 180,000 respondents across 38 countries of Europe and surrounding areas, to an index of this type of structural stigma surrounding gay and bisexual men in each of those countries, with the countries in red roughly being the most structurally homophobic countries, and those in green being among the most LGBT supportive countries in the world. And we found that for every 1 unit increase on our structural stigma index, we found a 21% decrease in MSM being screened for STIs, controlling for personal demographic covariates and various country-level covariates like income inequality. We also found that our index of structural stigma was associated with the 53% increase in odds of not disclosing one's MSM status during STI testing, which has implications for extragenital screening and testing, and similar increases in lack of STI prevention knowledge, lack of condom use, and lack of STI and HIV testing. Yet the strongest association with structural stigma was sexual orientation concealment, with every unit increase on our index being associated with 150% greater odds of an MSM concealing his sexual orientation from all other people in his life, or from the vast majority of other people in his life. In fact, here you see that in countries like Macedonia, Serbia, Romania, where we do work, up to 80% of MSM say that they've never told another person in their lives that they were having sex with men, or reported that they told very few people in their lives that they were having sex with men. And in fact, these associations between structural stigma and these STI-related prevention outcomes were statistically mediated by sexual orientation concealment. These patterns of findings led us to hypothesize that structural stigma keeps MSM underground and out of reach of traditional STI preventive services, but also keeps them out of reach of the right to simply express themselves. These results also provide evidence that sexual orientation concealment serves as another mechanism through which stigma might drive sexual orientation risk. This is true for MSM in Europe. It's also true for MSM around the world. From our structural stigma index, we estimated that about 80% of the world's gay, bisexual, and other MSM had never disclosed their sexual identities or done so to very few people. And it's also true in the US, where we estimated that about a third of sexual minority men in North America conceal their sexual orientation from all or most others in their lives. And recent data by Micah Latner and Mark Katzenbuehler at Columbia show that this is particularly true for MSM living in the most structurally stigmatizing US states. So the good news is that the mechanisms that I just covered are all cognitive, affective, and behavioral in nature, and therefore serve as potential targets for cognitive behavioral interventions. But until recently, no evidence-based treatment had been aimed at these stigma-related processes to reduce STI or other behavioral risks. So to create such a treatment, we interviewed behavioral health experts in the community who had spent their entire careers working with MSM. We interviewed young MSM themselves who were at risk of STI and HIV infection. And we consulted the research literature to create a treatment, a cognitive behavioral-based treatment that could provide sexual minority men the tools to understand and address the ways that stigma gets under their skin to compromise their mental and behavioral health. And I'll just briefly tell you about the treatment. So because many young sexual minority men blame themselves rather than stigma, the treatment first increases young gay and bisexual men's awareness of the damage that stigma does to their health. Simply, it's not them, it's stigma. We also teach them skills for reducing the avoidant coping strategies that they might have learned across their lives, things like constantly searching for validation on sex-seeking apps. Sometimes this avoidance is so severe that many men in our studies will report not even knowing what they feel, or that they turn to alcohol, drugs, and compulsive sex to numb the painful feelings. Nearly all of the expert clinicians we spoke to noted that they had seen deficits of assertiveness in the behavioral repertoires of their gay and bisexual male clients. And these assertiveness difficulties manifested themselves in silencing their authentic voice, including in condom use assertion. And so we work with the men in the treatment to help them consider the benefits of living authentically versus constantly sneaking around or silencing themselves. A lifetime of stigma can also cause cognitive biases, such as anxiously expecting rejection and believing, especially implicitly, in one's own inferiority, that one's not worthy of love and acceptance in intimate relationships. So we rework these cognitive biases by helping the young men in our study rework the lessons that they might have held on to for their entire lives. And our research consistently shows that sexual minority men have a hard time finding supportive community and often perceive the sexual minority men's community itself as unwelcome and stressful, especially as those communities have moved online, and especially for racial and ethnic sexual minority men. So therefore, we help the men in the treatment intentionally engage in the work of building supportive community to find a meaningful niche within that community as a support against stigma-related isolation. So we teach the sexual minority men in the treatment these CBT skills to help them start overcoming the painful patterns of thinking and behaving that many of them have held on to for their entire lives, and that set them up for risk. So we call this first treatment for young sexual minority men ESTEAM. ESTEAM here stands for Effective Skills to Empower Effective Men. In a small waitlist controlled trial where we initially delivered this treatment one-on-one across 10 sessions to 63 young gay and bisexual men. And we found that, looking at the lines in blue, which was the treatment group compared to the waitlist in gray, that the treatment did help the men gain more control of their sex lives, assert condom use more, as well as reduce depression, anxiety, and alcohol abuse. So we're now testing this treatment in a multi-site trial in New York and Miami with results due in a few months. We've also tested a group version of this treatment adapted for the intersectional stigmas that young gay and bisexual men of color face, with Black and Latino sexual minority men being one of the highest risk groups for STIs in the US. We did this because we were approached by a local provider in New Haven who said that she couldn't continue to diagnose the young MSM in her clinic with STIs and HIV without knowing that she was doing something more to support the psychosocial burdens placed upon this population. So we worked with her and we worked with members of the local community to deliver this treatment in a group-based setting. And the treatment worked. Just to summarize the results succinctly, almost every single young man that we interviewed in the follow-up interviews about the study said that it was the first time that they had felt not so alone, to see themselves reflected in their community members who were striving for health and well-being against kind of synergistic threats to that well-being, opened their eyes and was a helpful experience. And so also now in a large nationwide RCT, we've started delivering this treatment online to LGBT young people living in the highest stigma, lowest resource locales of the US, using an internet-based CBT platform developed in Sweden, which requires about 75% less therapist time. It's asynchronous, so the therapists don't have to show up at the same time as the participant. It's self-guided with asynchronous therapist support, which allows sexual minority men to receive this support anytime, anywhere. And one question here is whether the stigma coping focus of this treatment is especially needed in these particularly isolating, high stigma places across the country. And in fact, one concern identified by Alicia Reed is that our behavioral STI prevention interventions often aren't effective for stigmatized populations when adaptations aren't made to those interventions to address the structural context surrounding them. So for instance, in a meta-analysis of HIV prevention studies, she finds that in structurally racist environments, defined as those with high racial residential segregation and negative community attitudes towards Blacks, the efficacy of HIV prevention interventions for people of color was zero. Yet when adaptations were made to those interventions to address the lived realities of people of color in the interventions remained efficacious, highlighting that our behavioral interventions must attend to the structural context in which they're delivered in order to be effective. So I'll conclude with that and look forward to your questions. I also just want to acknowledge the collaborators and research teams on this work. Thank you.